Good morning. My name's Laura Politte. I'm a child psychiatrist at UNC in North Carolina, and I wanted to thank Sabrina and University of South Florida for asking me to do this webinar. And I'm going to be talking about managing physical problems and medical comorbidities, specifically in autism spectrum disorder today. And to give you a sense of what we'll talk about, I've divided this presentation into two parts. The first part is the longer one, and in that section I'd like to talk some about my approach to evaluating medical problems in people who have autism, and specifically we're going to focus on identifying some common medical comorbidities that are overrepresented in people who have autism. There are three main categories we'll talk about there. And we'll talk some about how these kinds of medical problems might contribute to behavioral presentations within autism, which is where I typically encounter them. And then we'll talk a little bit about how medication side effects can influence behavior and vice versa. And then some general principles that are just good to keep in mind when we're thinking about using behavioral medications in people who have autism. And then we've saved a little bit of time at the end to go over the updates to these 2017 best practice guidelines for prescribing, and these were recently published and available, so I think they're a really great resource and have a whole lot more detail than we'll talk about today, so I would encourage anyone who wants more detail to definitely refer to those guidelines. This is a case illustration that I use just to illustrate how complex and challenging it can be to tease apart behavioral and physical issues in somebody who has autism and how to ensure that they're getting really comprehensive care. And this is a kind of a composite of some of the problems that I have seen in my practice, but pretty true to life. So KM is a 33-year-old man who has autism and intellectual disability. He does not have any expressive language. He has a history of intermittent agitation, and that typically would include hitting himself in the head, vocalizing or whining loudly, and becoming very agitated and restless. And he also has a pretty significant history of recurrent ear and sinus infections for unclear reasons. He usually, when he has a change in his behavior, it very often does signal that he has a new ear infection. He has an ENT, but his mom feels like his problems really haven't been thoroughly addressed. He gets antibiotics, he's dismissed. There's usually not much workup beyond that. So we did refer him for a second opinion at an academic center ENT. He went to the appointment, but unfortunately, he had to wait about 60 minutes for that appointment to begin, and by the time it did, he was already agitated and could only tolerate a very brief physical exam. He had a chronic cough and was given some antibiotics and asked to go to a different facility to get a chest x-ray. But because he was so agitated at that point, his mom took him home. It never got done. He has a number of chronic problems that include a nighttime cough, severe sleep disruption, hypertension, obesity, and I note here he's been on an antipsychotic since childhood, and now signs of hyperglycemia and insulin resistance. He's also been treated in the past for gastric reflux. So that gives you a little bit of a taste of what we might see by adulthood in individuals who have autism and have been treated along the way. A few key points I just want to start this talk off with, and some of them may seem obvious, but they're really important to keep in mind when you're seeing kids and adults in this population. First is just to remember that people who have autism get sick just like everybody else, and they may not express that in the same way that other people do for a variety of reasons. That might be related to their communication impairment, their language ability, and some sensory differences that might actually influence how they express discomfort. That might relate to pain tolerance and to tactile sensory sensitivities. And with that in mind, I just make a point here that the first sign of a physical problem may be a behavior change. And that should always be our default when we're evaluating a behavior change. So I write here that not all behavior is behavioral. And what I mean by that is not every behavior is attributed just to autism or just to a developmental disability, but rather our first thought should be, okay, let me make sure that this isn't a medical problem that might be overlooked. And with that said, there are some medical problems that are overrepresented in people who have autism. We'll dive a little bit further into those, but that includes GI problems, seizures, and sleep disturbance. And I make a note here too that for obvious reasons, doing a really good physical exam on somebody who's agitated or who's hyperactive or sensitive to touch can be really challenging, but it's often worth that extra effort to diagnose some of these problems. We know well that medications can be part of the problem and certainly can contribute themselves to behavioral presentations. And I note here that parents really know their kids so well, and it's easy sometimes to overlook their input, but I find often that my biggest tell is that parents really know when their child is not their child and when their behavior is different from their baseline. And so I rely an awful lot on parents to help me decide how concerned I should be about a physical problem. And usually they're right. This is one approach to a medical evaluation in someone who has autism. And these are things that I focus on routinely in a first meeting and then periodically whenever someone is presenting with a change in their baseline behavior. Certainly, I start always with a routine medical history, past and current problems, medications, and allergies. But I'm also focusing it a little bit more on those problems that are more common in autism, including those three comorbidities listed at the top. And I'm also trying to identify with a behavior change, are there certain sources that we might need to rule out or attend to? That might be headaches. That could be dental pain in someone who's at the age to be cutting wisdom teeth, or for someone who has a hard time tolerating toothbrushing, might they have a tooth infection or abscess. UTIs is fairly common in younger children. Otitis media, ear infections, and occasionally even I've seen fractures. And particularly that's on my radar for people whose repetitive behavior involves some degree of stomping or hitting or manipulation that's particularly intense. I'm also thinking about any chronic medical problems that might set somebody up for more problems with side effects or for a differential response to some of the medications that we commonly use. An example might be somebody with epilepsy may be more likely to experience seizures when they're put on things like antipsychotics or SSRIs. And so I want to be mindful of any background problems that might influence our prescribing. And then certainly if there's any testing that might help us to rule in or rule out certain problems like seizures or hearing and vision problems, that might be part of the picture. So it can be difficult to figure out when we should think about a physical problem and when we can feel more certain that behavior is more functional or a symptom of their autism. And there are a few things that I focus on in particular. So probably the most important is, what is their baseline? And is this change in behavior sudden? And is there any clear precipitant to that behavior change? So, sometimes it's easy to identify that there's a function to a behavior. So, a child who is asked to do something they would prefer not to do, like do some work assignment or take a medicine, and they'd rather not do it. You might see some head banging in that moment, and then there feels like more of a clear connection between what's happening in their environment and what's happening with their behavior. Sometimes things start abruptly and it's really difficult to identify whether there's something causing that behavior. That to me is sometimes the sign that we need to dig deeper to look for a physical problem. So certainly if there's a new onset of sleep problems, I might be thinking about things like reflux or constipation that might be causing some discomfort in the middle of the night. If there's self-injury that's different or that's focused in particular on one body part, I want to rule out that there isn't a problem with that particular body part. So if they're hitting their head, might they be experiencing headaches? Someone who's pounding their chest might be experiencing symptoms of reflux, or biting their hand might have some tooth sensitivity. And then this is more intuitive, but if there's exam findings that can give us clues to what might be happening. So a child who started limping might have an injury from repetitive stomping or jumping. Someone with a distended abdomen may be constipated. And I also am thinking about what medications they've started recently to think about whether there might be a side effect that's influencing their behavior. So I've mentioned these already, but the three main medical comorbidities that seem to be overrepresented in autism that we particularly focus on are seizures, gastrointestinal problems, and sleep disturbance. And I'll talk about each of these in a little more detail now. So starting with seizures, we know that there is a higher prevalence of epilepsy and seizure disorders in autism, somewhere in the range of 25 to 35%. And we know that that prevalence actually is higher among those who have more severe intellectual disability. So the more severe the disability, the more likely they are to have seizures. And we do see this bimodal peak of onset for seizures. And so I'm thinking about that in particular in these two age ranges. One is early childhood, the other is adolescence, so 11 to 18. Less common do you see first episodes of seizures in adulthood. The most common variety that we see are partial complex seizures, which can be really challenging because a lot of those seizure repetitive behaviors can mimic or look a lot like the motor stereotypy that we see in autism. We do know that kids with autism who have seizures are more prone to behavioral challenges. Often their symptoms of autism are more severe, and their degree of developmental delay is also more severe. And we also know that having a diagnosis of seizures early in childhood can actually delay the diagnosis of autism because of this complexity and overlap with things like repetitive behaviors and communication challenges. So it's not always clear-cut, but there are some behaviors that might raise your suspicion that a child is having seizures. Some of these are more easy to identify than others. Staring spells or sudden cessation of activity or unresponsiveness. These are things that we look for in neurotypical kids as well, but it's a little bit more challenging to pick up in a child who has autism because of their particular mannerisms or their baseline level of reduced responsiveness to name call or to social stimuli. So what I'm often thinking is that because we know the prevalence is higher and sometimes these things are hard to sort out, usually our threshold for ordering something like an EEG is lower for a kid with autism compared to a child, a neurotypical child who might be presenting with similar things. Eye fluttering or eye deviation might be a clue. Or if their repetitive behavior appears rhythmic, if it appears one-sided or unilateral, or if it appears below their awareness, or if it's coupled with a change in responsiveness. And certainly if that behavior change is followed by confusion or drowsiness, that always would raise our suspicion for a seizure activity. In terms of treatment, there really is no particular difference in what kinds of medications are available to treat seizures in kids with autism versus those without. And there's been some interest in trying to identify whether some anticonvulsants might also have some positive effects for certain behavioral targets in autism. There really is not good data to support that. There have been some studies of valproate or Depakote, but the data there is pretty mixed. Some studies have found some benefit for things like irritability and self-injury. Others have not found any change for those behaviors. There have been some small studies, single studies in things like Lamictal, lamotrigine, or levetiracetam. And again, there haven't been any findings of improvement for behaviors that were consistent. So it's difficult we always want to try to do double duty if we can. So if a child needs a medication for seizure, we may want to lean towards trying one that may have some benefit for behavior like valproate, or at the very least, trying to coordinate and make sure that I'm often trying to make sure I'm working with a neurologist so that we're not working at cross purposes and potentially exacerbating one problem at the expense of another with what we're doing. And always, as with any medication, trying to remain mindful of specific side effects that a child who has a developmental disability may be more prone to experiencing. Examples here might be cognitive dulling with topiramate, an increase in irritability with something like levetiracetam, or drowsiness and problems with alertness with benzos or valproate. Moving on to GI problems, we also know there's this pretty consistent and interesting finding that kids on the spectrum have more GI problems than their neurotypical peers. The prevalence is around 40%, which is pretty high. And those problems are primarily what we would consider functional as opposed to structural or anatomical. So the kinds of symptoms that you see are very similar to the kinds of symptoms that you see in children who have irritable bowel syndrome. So kids with autism have about a 4.5 times the odds of having any GI problem compared to neurotypical kids. And among those there are constipation is most prevalent, followed by diarrhea and then by abdominal pain. This slide is really to illustrate how complex the etiology of a problem like constipation can be in autism. And there are a lot of intrinsic factors and external factors that might be contributing to that problem. Probably one of the biggest problems is diet in children with autism. So you may know that kids with autism tend to have very self-limited diets that tend to be heavy on starches and carbohydrates, that are low in fiber, high in water, and also dairy, so foods that tend to bind rather than to increase bulk in stool. So partly it might be a factor of diet, and there are some other things that are likely to play into that as well. One is this issue of GI dysmotility. This is something that is of interest in research right now, but not entirely well established, but there is some belief that children with autism have differences in their rate of GI dysmotility. So you will sometimes see patterns of alternating constipation and loose bowel movements, or one or the other, for unclear reasons. Medication side effects are a big offender, and two of the most common medicines prescribed in kids with autism are alpha-2 agonists like clonidine and guanfacine, and antipsychotics, and both of those classes can have significant effects on GI motility. Sensory aversion is an interesting component when we're thinking about GI motility. A lot of kids with autism are hypersensitive to tactile input, and they really dislike the feeling of things like sitting on a toilet or defecating or wiping. All of those things can contribute to stool retention, stool withholding, which of course can exacerbate constipation. And I'll talk a little bit in a couple slides about some new research around the gut microbiome and whether there might be some differences there that are contributing to motility and to constipation. Like with all medical problems, it can be a real challenge to pin down gastrointestinal problems in children who have autism because of their difficulty communicating those symptoms and their sensory processing differences. So you may not be aware of a problem until it's presenting as a serious behavioral disturbance or other changes in behavior because of their high tolerance for pain or differential experience of pain. Some behaviors that I'm looking out for if I'm concerned about GI symptoms are things like tapping or pounding on one's own chest, pressing on someone's abdomen, or using a caregiver's hand to press on their abdomen. I've also seen young people who would want to get in the bathtub or ask for a bath anytime they were having GI pain, and that seemed to be soothing to them. So sometimes we can get clues from an individual, and parents are pretty good at figuring this out too. If I'm seeing an increase in irritability symptoms, physical aggression, self-injury, tantrums, crying, complaining, when there's no clear precipitant, or again, if that's tied to stooling or to toileting, then that can, of course, be a sign that there's some pain or discomfort. And if I see a child who has a new sleep disturbance, I'm sometimes wondering about their GI symptoms. I have a pretty low threshold for referring to a gastroenterologist if I'm suspecting a problem, and if families have tried routine interventions like Miralax and probiotics and increasing fiber and water content in their diet without a lot of success. And once we get to that point of treatment, like with seizures, the guidelines for treating things like constipation and functional abdominal pain are really the same in kids who have autism versus kids who don't. One caveat here is that we have more and more evidence from studies that kids, at least a subset of kids with autism, may have differences in their microbiome makeup that might be contributing to some of these motility issues. So that's still a work in progress, but pretty consistently studies have shown that this subset of children with autism has a different microbial signature, which typically includes less diversity in species of microbial agents, and then also an overgrowth of certain species, and particularly Clostridium species. So that's been shown and documented in several studies. There was one recently published study comparing kids with autism and functional GI problems to neurotypical kids with functional GI problems. And what they found was the kids with autism did have higher levels of Clostridium, both within their stool and on intestinal biopsies. And that was associated with higher levels of abdominal pain and higher levels of inflammatory markers like interleukin 6 and interferon gamma. And also when there was pain within those functional GI problems, that seemed to be associated with higher levels of serotonin metabolites. So it's also well documented that a subset of children with autism do have higher serum levels of serotonin, and how all of these things are linked together is not entirely clear and something that people are very interested in trying to sort out. There have been a few studies, preliminary studies, looking at probiotics as a treatment for kids who have functional GI problems with autism. There seems to be some promise in terms of improvement in GI symptoms, but there haven't been any studies to date that have clearly documented improvement in autistic behaviors or in behavioral symptoms that are associated with autism. And in a similar vein, there haven't been any studies of other dietary manipulations, including things like gluten-free, casein-free diets that clearly show superiority for treating behavioral problems within autism. I wanted to spend a minute talking about the problem of overweight and obesity, because while this is a growing national trend and it's a problem across the board, neurotypical and autism, it does seem to be a little bit of a higher prevalence within autism. So a difference of 40% compared to 32%. And those differences are apparent very early on, as early as 2 to 5 years old. And like with constipation and other GI problems, there's a number of biological and environmental factors that are probably contributing to that higher prevalence. Again, at the top of this list is self-limited diet. So foods that are high in processed sugars and fats tend to be appealing to all of us, but particularly to some children who have sensory aversions to foods like vegetables and fruits. So you do see a higher content of junk food and starchy foods in diets. That's probably a part of it. Also, this use of what I would call edible reinforcers. So if you're familiar at all with behavioral training programs like Applied Behavioral Analysis, ABA, there's often a reward for doing a non-preferred behavior or a task that's difficult for a child. And often food is used as that reward. It's pretty motivating for a lot of children, and it works well. But the flip side of that, of course, is that kids may be getting lots of candy throughout the day to try to motivate them to perform certain behaviors. And so that can become problematic over time. Medication side effects, as you're probably all well aware, antipsychotics cause a lot of metabolic problems and weight gain, and that's probably the most commonly prescribed medication within children who have autism. So that certainly is a contributing factor. sleep disturbance. We know there's a connection between poor sleep and weight gain, and so that's also true for children with autism. And then there are some studies that show kids with ASD are more prone to decreased physical activity, higher amount of time spent per day on screens, so computers, TVs, phones, tablets, things like that. And so all of these could be targets for weight management in children who have autism. And along those lines, there are some anticipatory guidance that I like to go through with families and with children, particularly if we're at the point where we might be considering starting an antipsychotic, or we've already started one and they've developed some problems with overweight or obesity. The first is making sure that they're getting plenty of physical activity. It can be really challenging for families to find activities that are safe, that their child can participate in, and that their child enjoys. So sometimes we're trying to capitalize on their particular sensory preferences. So many kids will enjoy things like swinging, jumping, bouncing, things like low trampolines can be very helpful. Even just running in the yard, taking family walks, and thinking about organized sports activities that might also give them a sense of community. Special Olympics is everywhere, and it's a really great organization, but certainly there's a lot of other special needs sports leagues out there. YMCAs will sometimes have programs for children who have special needs. And for older teens and adults who are higher functioning, a gym membership, working with a personal trainer is another option for making sure they're meeting their physical activity needs. The other thing I explained to families is that this physical activity is also really important for helping them self-regulate and to kind of meet their sensory needs, and can be very helpful for symptoms like hyperactivity, agitation. So there's a lot of multiple benefits to trying to work on physical activity as a lifestyle adjustment. We try to recommend limiting use of food as a reward as much as possible, and thinking more about activity-based rewards. So thinking about their preferred activities, whether that's some time with a tablet or some time with a special toy or a favorite interest or activity, that can sometimes be an effective substitute for food rewards. Of course, we're talking about trying to limit access to processed foods, junk foods that might be contributing to a weight problem. This is a real challenge, I think, for families that have multiple children or different family members who have different dietary habits and needs. But what I've really found is for this to be effective, the families really have to make a family change across the board. It's not really fair or feasible to expect that their child will have the self-control to not eat those foods if they're in the home. So if their child knows there's 2 cartons of ice cream in the freezer, that's going to create problems that could lead to tantrums and meltdowns if they're not allowed access, or if they see other family members eating those things and they're not allowed to have it. It's really just much easier not to have those things in the house, so out of sight, out of mind. Setting time limits for screens can increase physical activity, can limit the amount of sedentary time that kids are getting. That's not just for kids with autism, of course. Making sure that their sleep pattern is addressed, and that their sleep schedule is optimized as much as possible so they're not eating late at night or early in the morning. And then I put in here for children who are benefiting from an antipsychotic and really can't stop easily for behavioral reasons. There has been some study recently of metformin in children with autism that showed some benefit for insulin resistance and for weight gain. And I would refer you to that reference if that's something you're interested in for guidance around dosing and things like that. All right, moving on to sleep. This also is a well-documented feature of autism. Problems across the board with sleep onset, sleep maintenance, and early awakening, all of those have been well documented. And we also know that problematic sleep can affect daytime behavior, can affect levels of attention and cognition and daytime performance at school and in other arenas as well. There's probably too many factors to name that are influencing sleep patterns. I put some of the most common ones here, but we could probably talk for 2 hours just about sleep and all the different factors that contribute to sleep disturbance in kids with autism. Some of the more common things we'll see, there's a pretty clear connection between melatonin synthesis and sleep disturbance in autism. So kids on average tend to make less melatonin, so that really affects their ability to get sleepy when other people are getting sleepy and to regulate their sleep-wake cycles and their circadian rhythms. I think about sleep as a transition. Difficulty managing transitions is a hallmark of autism. So we do see that this transition from awake to sleep is a pretty big state transition. So it's expected that you might see some challenges and might need to apply some of the same behavioral supports around that transition as you might for other activity transitions. Problems with hyperactivity and heightened physiologic arousal are also extremely common. That can make it really difficult to shut down and turn off when it's time to go to sleep for some of these children. And all of those challenges funnel into problematic sleep hygiene and habits that can really add and contribute to those problems. And I'll talk a little bit about that on the next slide. Anxiety can make it difficult to fall asleep. Medication side effects, particularly stimulants, SSRIs, all of those can have interference with sleep patterns. Obstructive sleep apnea, so enlarged tonsils or adenoids, or even excess tissue from obesity can contribute there. Iron deficiency can lead to restless leg syndrome. I worry about this in particular with my kids who have very limited diets and who might actually be iron deficient, and sometimes checking levels is helpful to rule that in or out. And reflux, particularly for kids who are waking up in the middle of the night or who have some other symptoms like a nighttime cough or daytime symptoms as well. Okay, so I spend a lot of time in my practice evaluating sleep problems because sleep disturbance can have such a profound impact on behavior during the day also. And the first thing I want to establish is when that sleep problem is happening. Are they having trouble falling asleep but then sleeping fine? Are they falling asleep fine but waking up in the middle of the night and staying awake? Or are they doing all right until it's 3:30, 4 o'clock in the morning and then they're up for the day? And that's going to really influence what kind of interventions we might be using and will point us toward what factors might be contributing to that problem. And then once I've established that, I usually will conduct a very detailed review of bedtime habits and behavior. So I want to know things like when are they getting into bed, and then how long does it take them to fall asleep once they are in bed, and what's happening in that latent period between going to bed and falling asleep. What is their typical bedtime routine like, if any? How involved are the parents in getting to sleep? So do they need a parent lying beside them, rubbing their back, sitting beside the bed, and is that interfering with their ability to get back to sleep if they wake up in the middle of the night? What are their sleep conditions like? So it's worth asking because sometimes you'll find a child wants to sleep with all the lights on, or they're sleeping in a room that isn't air conditioned in the summer and is very hot. Or they might be sleeping with 2 or 3 siblings in the same bed and they're waking up when their brother or sister makes noise or rolls over. Or there might be a lot of activity going on outside the room that's making it hard to fall asleep. And then are there any sleep behaviors that parents have noticed that might signal some kind of problem like sleep apnea or restless legs? Are they moving a lot? Are they sleepwalking? I spend a lot of time talking about sleep hygiene. I put use of screens here in italics because I find that to be such a prevalent problem in autism and kids without autism these days. So it's problematic for a couple reasons. One, we know that all these activities like games and social media are extremely engaging and even addictive and hard to turn off. That's maybe even more so true for kids with autism. But also that typical glow that the screens give off can actually interfere with endogenous production of melatonin, so it can actually interfere with their ability to get sleepy. So I always preface these conversations to kids by saying, I'm not very popular for bringing these things up, but I really recommend shutting off screens for at least 30 to 60 minutes before bedtime. If parents look at me like I'm crazy and there's no way that's going to happen, I say at the very least, turn down the brightness on the screen so that it's dim, or use one of those backlit Kindles that looks more like regular paper as opposed to a screen. I want to figure out if they're drinking any caffeine late in the day. Are they having a high level of physical activity right before bedtime, or are they not getting enough physical activity earlier in the day? How much light is in their room when they're trying to sleep? And then, of course, thinking about whether there might be medications there that are contributing to problems with sleep. I'm going to move here and talk just for a few minutes about medication side effects, because this is so prevalent in kids with autism, and can contribute to physical health and things that I think we just all want to be mindful of. With antipsychotics, I know we're all well aware of some of these side effects, but overweight and obesity, this seems to be a big problem in autism, particularly given all those other factors that put them at a higher risk for being overweight. Fatigue and lethargy certainly contribute there. Constipation, lowered seizure threshold I put here because that is such a common problem, comorbid problem in autism. And then this difficulty in distinguishing stereotypic movement from EPS or even tardive dyskinesia can be extremely challenging. With stimulants, we know kids on the spectrum are more prone to behavioral side effects. So we're worried about things like irritability, worsened anxiety, heightened perseveration or motor stereotypy, and then worsened sleep disturbance, and then things that might be harder for them to report, like headache and stomach ache. I'm going to go quickly through these because we've talked about these a lot already, but anticonvulsants in particular, I'm worried about new onset of irritability, problems with cognitive slowing that might be impacting school performance. With SSRIs, I'm worried especially about behavioral activation. So is it exacerbating problems with sleep, with hyperactivity, and with irritability in particular? These are things that are just helpful to know up front. We know there's no medications available at this time to treat core symptoms of autism, so most medications are focused on treating target behavioral symptoms that we'll talk about in just a little bit. There are 2 medicines that the FDA has approved specifically in autism. Both of them are to treat irritability, meaning aggression, severe tantrums, and self-injury. Those are risperidone and aripiprazole. Everything else is considered off-label. And behavioral and education interventions really are the mainstay, both for core symptoms of autism and for many target behavioral symptoms that go hand in hand with autism. So there is a limited body of evidence. It's better for autism than it is for things like idiopathic intellectual disability, and certainly there's more data for autism than for rare genetic syndromes, where we're often extrapolating data from autism studies to guide our treatment strategies. These are some principles that could apply to child psychiatry in general, but even more so to kids with autism. The most important thing is that making sure you've identified that there is a target symptom that might be amenable to improvement with the medication. And often there are multiple problems. It might be hyperactivity, sleep disturbance, anxiety. And when that happens, what I'm trying to work through with families is what is the highest priority for us to get in good control of first. And then trying to choose medications that might do double duty to treat 2 problems at once, if possible. I always start at a very low dose. I increase it very gradually to try to minimize those risks of side effects. Sometimes I'll use liquid preparations of those medicines to get to a smaller starting dose if I need to. I'm very clear with families that we need to make just one change at a time to be clear about what that medication is doing. That seems obvious, but you will see sometimes there's a push to want to get a lot of things better very quickly, and I've seen multiple medications started at the same time, titrated at the same time, and it becomes very muddy to sort through what medication is doing what, or even contributing to side effects. I ask families to treat complementary and alternative treatments and medications the same as they would medications. I think that, that means starting with a target symptom. What do you expect to improve? Setting a timeline for when you expect to see that improvement, and then what you'll do if you don't see improvement within that time frame. I think that avoids building up multiple supplements and things that could contribute to health problems, contribute to financial burden, and really helps families to be clear about what they're doing. We want to be realistic about what meds can and can't do. I don't promise things that I don't think are possible. And as much as possible, I want to avoid polypharmacy. We know that the more medications there are, the higher the risk of side effects and things like that. But also acknowledging that multiple trials might be needed. And then being aware of some of these unique susceptibilities in kids with autism to side effects. Okay, I know we're running short on time, and I want to make sure we've got time for questions. I might take maybe 5 or 6 minutes here to talk some about those updated prescribing guidelines. And again, if you want that detail, please go to the published version. I'm sure Sabrina can point you to where that's available. I think they're really useful guidelines. When we met as this expert panel in February, we were talking about prescribing guidelines for target symptoms in 7 key areas that are listed here. And I'll go through those briefly with you now. Probably the most common target symptom treated in autism is symptoms of ADHD. We know at least half of kids who meet criteria for autism may also meet criteria for ADHD. And so I'm not going to spend a whole lot of time with these guidelines talking about level 0. It's pretty similar across the board. That means a comprehensive assessment. And ruling out physical problems, ruling out environmental contributions, making sure that all those stones are unturned first. Moving on to level 1, which really means that there is a strength of evidence there that makes us feel confident about what we're recommending. The treatment guidelines here specify either methylphenidate as a first-line treatment, immediate release, or extended release seems to be equally effective. Or this is new as of this year, considering guanfacine, either as its immediate release form or as the extended release form Intuniv monotherapy. There was a study published in 2015 by Larry Scahill and his colleagues showing that the response rates for Intuniv look very similar to response rates for methylphenidate. And for some kids that may be better tolerated, for kids who really do struggle with those behavioral problems or sleep problems that are a byproduct of stimulant use. It can be equally effective for hyperactivity. I would note here that if concentration is the primary target, stimulants are probably a better bet than guanfacine, although for hyperactivity they look pretty equivalent. I will say amphetamine salts have not been well studied in children with autism. Doesn't mean that they're any better or any worse, but most of the literature has been focused on methylphenidate. If a child fails both guanfacine and methylphenidate as a first-line treatment, then we're thinking about level 2 treatments, and that might be combined methylphenidate and guanfacine for kids who are a partial responder to one or the other, or to consider atomoxetine monotherapy. I made a note here that you want to be careful always of combining alpha-2 agonists like clonidine and guanfacine, because that will increase risk of problems like hypotension and lowered heart rate. And also just to be mindful that response rates for stimulants in kids on the spectrum are lower than in neurotypical kids with ADHD. They're more like 50% as opposed to 70%. And certain behavioral side effects like irritability are more common. For irritability and aggression, of course, starting with a comprehensive assessment and ruling out all those medical problems that we talked about. Level 1 really is thinking about behavioral interventions, and there's a good amount of data behind ABA in particular. That's applied behavioral analysis. But moving on from there, we would consider an alpha-2 agonist like guanfacine to be second line for things like mild to moderate symptoms of irritability. By that I might mean mild hitting, mild self-injury, temper tantrums that don't involve a level of safety concern. So we're not worried about a child doing significant damage by those behaviors. If they're at a point where those behaviors truly are reaching a point of crisis and safety is a concern, then we're usually thinking closer about risperidone and aripiprazole. And again, both of those medicines are FDA approved for treatment for this purpose. For anxiety, there is really very little evidence to support medication interventions for this particular problem in autism. So first line you'll see again is psychosocial interventions. There is a wealth of research to support cognitive behavioral therapy, although with the caveat that that really applies mostly to higher functioning, more verbal children and adults, and has not been well studied in nonverbal or minimally verbal people. Beyond that, we're really borrowing recommendations from pediatric anxiety disorders literature. So thinking about fluoxetine and sertraline as first-line agents. And also this year we added Busparone to a level 2 intervention based on some newer studies looking at Busparone in children with autism between the ages of 2 and 5. There were some secondary outcomes showing some improvement with Busparone, which many times is better tolerated than SSRIs in terms of behavioral activation. All right. For sleep disturbance, first line again is thinking about those interventions, thinking about sleep hygiene, parent training, graduated extinction if there is a parent who's heavily involved in that child's sleep routine and the child has become dependent on the parent to help them fall asleep. Beyond that, melatonin has well-documented benefits for many kids who have autism and is relatively safe and available over the counter. So we're thinking of dose ranges there anywhere from 1 milligram up to 10 milligrams, given 30 to 60 minutes before bedtime. And if that's not effective, then we establish clonidine as our next recommendation. I included everything else in one slide because the evidence really is so limited. For restricted and repetitive behaviors, we went back and forth in this expert panel about whether those should be treated at all, and we all agreed, I think, that only if they are significantly impairing their functioning or interfering with their normal routines do we want to consider treating it, and actually considering that there is a value to some kinds of repetitive behavior. So for many kids, they're soothing and they provide some sensory relief, and so we wouldn't necessarily want to take away that type of behavior altogether. For mood disorders like depression and bipolar, there is very minimal research that's specific to autism. And so what we agreed upon is really considering that challenge in diagnostic overlap between symptoms of things like depression or bipolar disorder and autism. And then if the suspicion is high for mood disorders, following the treatment guidelines for pediatric mood disorders. Catatonia is beyond the scope of this talk, but there again is a fair amount of overlap between symptoms of autism and catatonia. And if this is something that's high on this differential, referring to a child and adolescent psychiatrist or a neurologist for consultation is the primary recommendation. Psychosis, again, there's a lot of diagnostic overlap. One thing I always just want to make a point of in these kinds of talks is pointing out that self-talk is very common in autism, and self-narrating of thoughts or experiences is common. And it's really important to distinguish that from true hallucinations, where the child is actually hearing voices and responding to voices. It's not always easy to tell, but I've seen cases of children who are self-talking, who have been misdiagnosed with things like schizophrenia and end up down a path of antipsychotics that never really work for the behavior. So that's something that's always on my radar. So most of the questions that I see here are related to finding the published guidelines and problems with technology. So if anybody had any content questions, I'd be happy to answer those if they want to type in, or if anybody on the technology side wanted to give their input about finding the guidelines. I'm going to direct you to Sabrina Singh. I think she's the expert on where to find them. I do believe that they are published online. I'm seeing one question here about experiences with N-acetylcysteine and self-harm. So that's a great question. There has been one small randomized controlled trial that's been published that looks specifically at NAC in children. And I think there were about 18 participants. It was placebo-controlled trial. They did find an impact for irritability and a trend towards significance for repetitive behavior, but I have not seen that replicated in other studies. My personal experience is I've used it occasionally. I haven't had dramatic results with it. And so I don't really have a recommendation one way or another. I think it's an area of interest that probably warrants some further study. And I don't know if we can draw a whole lot of conclusions from that one published trial, but great question. Someone's asking if we'll have access to the PowerPoint presentation. And again, that is available from Sabrina if anybody wants that. Let's see. I'm seeing a question here about Busparone dosing. Somebody, I think, who might be familiar with that study. So that randomized controlled trial that was recently published, I was referring to, did use two different dosing schedules. One was 2.5 milligrams twice a day. One was 5 milligrams twice a day. And one interesting thing is that they really saw the bulk of the effect in the lower dosed group, that 2.5 milligram BID dosing. It's not entirely clear why that was the case, but there is some thought because Busparone is a serotonin receptor partial agonist that you may see a dosing effect in that regard, that it works well when the dose is low and less well when the dose is high. I think it'll be interesting to see if that pans out, but my personal starting dose is always either 2.5 milligrams once or twice a day and increasing from there. Okay, I'm seeing a whole lot of questions coming in. I'm going to just go to the top and see what I can pull up here if I can. Are you familiar with the use of drugs used to treat aggression that are also used to treat dementia, such as Zyprexa? There have been a couple of studies done in other atypical antipsychotics that are not risperidone and aripiprazole. They're much smaller, and so there's much less evidence. For Zyprexa in particular, I have seen some studies that did show some benefit, and pretty similar to what you might see with risperidone or aripiprazole. The reason those aren't used more often as first line is because of the metabolic side effects. So they also saw huge jumps in weight gain even in these 6 to 8 week studies. And so I think that my feeling is that they can be effective, but for me, they're generally a third or even fourth line treatment because of the metabolic concerns there. Are there any studies on omega-3s? So good question. I'm aware of one study that was looking, it was an interesting design. I think the primary emphasis of the study was testing this web-based method of collecting data. So they had kids who were taking omega-3s, and then the families were filling out surveys online. So I don't believe the primary focus there was on efficacy. What I did see from that, though, was their preliminary evidence did not show any behavioral improvement with omega-3s. Again, I think the data there is pretty limited. Has there been any research on the use of medical marijuana with severe autistic disorders in reducing self-harm? The answer there is no. There is a real interest in cannabidiol, which is a cannabinoid. It's not the same as medical marijuana. It's derived from cannabis, but it has a very low content of THC, which is the part that causes the euphoric and hallucinatory effects. So there is a pharmaceutical in the pipeline that is being looked at for severe forms of epilepsy, things like Dravet syndrome and Lennox-Gastaut. there is some interest in whether cannabidiol may also improve behaviors in things like autism and other genetic syndromes, but there are no research studies to date. I suspect in the next several years there will be something there. Okay. What is your experience with parents who believe their child is over-infected with yeast, wishing diflucan script? I do see this from time to time, and people who have been tested, and I look at the testing and I never can make sense of what's actually being tested. And so my general approach, and this is just me, is to say this is outside my area of knowledge. I'm not aware of any studies that connect yeast overgrowth to autism. And so my general practice is not to prescribe things like diflucan and to kind of uninvolve myself from those kinds of approaches. Let me see here. I have a ton of patients on Intuniv and then clonidine both at night. For me, that is not, for me, my worry is mostly around hypotension and heart rate. Every so often I'll have somebody taking Intuniv in the morning and clonidine at night, but I think in general that is a concern, particularly because they're peaking at different times, and if they happen to kind of reach their peak at the same point in time, there could be problems overnight that are difficult to pick up on. Okay. Are there any biomarkers for the GI flora available or in development? That's a great question. I'm not incredibly well versed on the literature looking at microbiome and autism, and I don't believe there's any standardized testing right now. So I don't really have any recommendations for pointing people toward that. Okay, let me see if I can get through maybe one more question here before we wrap up. The next one I see is, what's your experience with Trileptal for behavioral symptoms? If I recall, I think there have been some small studies looking at Trileptal for behavior symptoms in autism. I don't believe that they were all of that convincing. I kind of have used it at times in a moment of desperation where everything else seems not to be helping, but it's generally not high on my list of recommendations because there is limited evidence, and I haven't had a lot of personal success in seeing improvements with that, unless there is behavior problems that might be tied to seizure disorder or to something like comorbid bipolar disorder. Let's see. I probably should wrap up. I know it's 1 o'clock and we're on a schedule here, but thank you all very much for your questions. I'm sorry that I didn't get through all of them. If you want those guidelines or the PowerPoints from this presentation, please connect with Sabrina Singh, whose email address was at the beginning of this talk. All right, thank you.